Greetings, everybody. We start in 18 minutes. No. Good day, Juha, you there?
Hello, hello, John. Hello,
How you,
John.
how you doing?
I'm fine. I'm fine.
You've been away for a while, huh?
Yeah. It
A
is
couple of weeks.
the new year has changed here.
Yeah,
Okay.
is it the whole country shut down during the New Year's? Is a big celebration there?
Yeah. This is like Christmas in
Really?
West.
Wow. So it lasts more than a day, and you know, in America it's like one day, Christmas Day, and that's it.
Yeah, but this 1 week.
One
There is
week.
1 week. Yeah. Usually the whole China is traveling to their homes, but now it was not so.
Yeah,
Good.
it's still. I got my second vaccine yesterday. Have you got the vaccine yet?
No, Fitri has got one vaccine.
Oh, that's right. You
I have not
mentioned.
got.
Okay, yeah, you mentioned that. But yeah, it's very organized, but slow in this country. It's not as
I
fast.
don't know how it is going in China, but the number of new cases is extremely low. Six
Still
cases.
low. That's incredible.
6 cases yesterday.
Wow,
or today.
that is amazing.
Yeah.
That is amazing for a country. That's beyond incredible. Beyond incredible. But it just shows you it works. What they're doing works.
Yeah, somehow it works. Yes.
Hey, you know, it was really great news to see that Ben's interested in collaborating with artificial intelligence in Buffalo. Yeah, I know you didn't see the webcast, but he said, I want to know.
I will see during the weekend. Yeah, when I have time. I have been working this week, so.
Yeah, he came to the webcast. Ben did. But listen to this, Juha. It was a fantastic. Not only did Ben come to the PhD presentation from Buffalo, but Louis Borber came, and the biggest Chinese neurosurgeon in Beijing, the head of one of the big neurosurgery departments in Beijing was there too. So he hit a home run. Three of the best people in the world to see about, you know, artificial intelligence and neurosurgery were there in the webcast. It was fantastic.
That's great.
Yeah, to kind of, you know, making those connections. That's why this platform is really good. It makes those connections.
You are doing extremely well now. Yeah.
But
connecting the world.
Yeah, well, with artificial intelligence, it's necessary and it's doable. Just organizing it, because at the University of Buffalo, they want to establish data centers in neurosurgery, because that's what they're doing in this lab in Buffalo, neurosurgery research. They did 3D, and now they're doing artificial intelligence. So obviously they need data centers to get their information. So maybe that's our job, is to figure out what data centers are best in the world for neurosurgery. And maybe you can tell me what you think the areas would best suit data collection for neurosurgery. So just think about that, okay?
Yeah, of course. I will take a look during the weekend on this.
Just let me know.
With thinking,
Yeah, let me know what data centers you think are good. I'll try to contact them and say, hey, you want to get involved in this? Hello, Abby. Good morning.
Hello, Abby.
Hello, Professor Juha. How are you?
Oh, I'm fine. You?
I'm good. Just finished coaching and care.
Hardworking.
The king arrives.
The king.
He arrived with the usual fanfare.
There he is.
Hello, Juha.
The king is
Hello,
here.
Atul. Hello. Great to see you.
Hello, hello. How are you, Juha?
I'm fine. I'm fine.
The king is here.
Yeah, yeah.
He's
John,
Juha,
my
he's the
dear
king.
John, you are
Of course, of course.
He's the king of Zoom. He goes everywhere.
Yeah, yeah. Teaching all the world.
you are made the king, John.
Is it your
Juha,
camera
what is
working?
the news?
Your camera working there, Atul? I don't know if I can see you here. I don't know
Yes,
what's
yes,
going
yes.
I don't see your camera there. Just full with this. Unspotlight. Oh, okay. Remove spotlight. Okay. Are you there, Atul? Is your camera working?
Yeah, Juha.
Yeah. Okay. There you go.
Yeah, yeah, I'm
Okay.
very much here, John.
Okay. There you go. There you go. Yeah. Yeah. We got 5 minutes.
Okay. Subin.
Yeah. We're waiting for Ben. Right.
Subin and Takahashi.
You know, we had a Chinese translator for last night for the webcast. He's a fellow at in Arkansas, a Chinese neurosurgery fellow. He translated last night. It was a bad time for Ben because Friday morning, Friday morning is bad for.
That was Siley.
Yeah, and any neurosurgeon, Friday morning is bad.
But it was Siley. He's a young Chinese neurosurgeon in Arkansas, fellow.
Yeah, it's a regular work day, like this country. So. Good morning, Danu. Oh, there's Ben.
So, Juha, today is a spine day for you.
It's good. It's good. Yeah.
No, you will see something different,
hope.
I'm sure.
Ben is there.
Ben,
For me, it's okay.
Hi.
good evening, Ben. How are you?
Hi, good evening.
Good morning. Good morning.
Ben,
Fine.
you will now
Hi.
today see some spine. So
Yeah.
you must translate into some bypass surgery or something.
My pupil, Dr. Liao Yujun, will translate for you. He
Yes.
already prepared.
Yeah, last night he translated.
Mhm.
Yeah.
Yeah.
Did you see that, Ben, the last time? No.
What was the show, John?
Did you see the webcast last night? I guess it was a bad time for you, Atul. I think it was very early in the morning.
What was the title?
Dr. Lawton and Ali Krish
No, I
gave a
didn't.
presentation, but I think it would have been like 3 or 4 in the morning in India, I think.
Mhm.
Very, very bad time. Is it the rainy season now, Dr. Goel, in Mumbai?
No, what rainy season, John? It is.
There's no rainy season in Mumbai?
It is winter, pitch winter, and the temperature is about 30. So that is the beauty of this country. So
It's
winter is 30.
like Miami, like 30 degrees, Miami. But it's very muggy in Miami, like humid.
Same here, humid, Mumbai.
It's very muggy.
Tropical climate.
Yeah. Okay. We'll pick up more people as they come along. Good morning, Radab.
Hello, Dr. John. Good morning.
How
Good
are things
morning.
in Jordan?
It's quite stable, but we are going back to high numbers of COVID cases.
So it's increasing?
Yeah,
Oh, okay.
like a third wave, and we are in quarantine today.
How
Or
is it?
curfew, actually.
How is it in Mumbai, Dr.
We're
Goel?
in curfew.
Oh, okay.
Mumbai is little bit, is what had become quite good, but recently for last 1 or 2 weeks, the numbers have gone a bit. But
Okay.
I think it's still under control. I don't see. We are operating and working normally, so there is
Oh,
no.
okay. So elective surgery and normal
Yeah,
schedule?
absolutely, absolutely.
Okay, yeah, we're getting a lot more people coming into the panel now. So 1 minute, Atul.
Okay.
So I will make a short introduction again, because it was 3 weeks ago, or 3 or 4 weeks ago, we met. 3 weeks,
Yeah.
3 weeks, yeah.
a long interval.
Okay.
It's here. No, wait. Wait.
Okay, Dr. Goel, you ready?
Yeah,
I
yeah.
will make a short introduction.
I'm sorry?
I will make a short introduction.
Okay, I'll introduce you, okay, you are? Okay, 10, 9, 8, 7, 6, 5. Hi, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have another Juha's China Neurosurgery Grand Rounds, and we're graced with the presence of Atul Goel, a longtime user of Zoom. We call him the king of Zoom. He goes to all over the world giving presentations. I'd like to introduce Juha. Hello, Juha.
Hello, John. Hello. So I will give a short introduction, and then the king is speaking.
The name is spreading.
Okay, so Professor Atul Goel, the king, is now our guest speaker here. He's coming from working in Mumbai, India. He's the chairman of King Edward's Hospital, and he's one of the most important neurosurgeons of these times in the world. So how to become a good neurosurgeon? Train hard, follow the way Professor Atul Goel is doing. There are different levels of manual skills, and usually they depend on the number of repetitions and length of career. There is a general rule that to come to the world top, you have to train 10,000 hours, and I have added to it that you are at your highest level when you have done 10,000 days in operation room. And this is certainly Professor Atul Goel has done. Neurosurgery has 3 parts: operative skills, and then research, clinical research, and basic, and teaching. And like we heard, John was saying that Atul is everywhere. He's teaching all the world, and this is very important. He's doing a lot of operations, around 1,500 personal operations a year. This means that you have to be excellent neurosurgeon, organizer, surrounded by a good supporting team, and the patients and society. And of course, for that high number of operations, you have to have big flow of the patients. This means big country. Professor Goel is teaching young people, and hopefully, certainly in 10, 20 years, they will become better than us. This is our goal. And he's very supportive and has a great team around him and has brought India neurosurgery to the international highest level. So he has published a lot, more than 800 publications, and he was elected as one of the 69 most important neurosurgeons some years ago, 2014. The big neurosurgeon from Cushing, Dandy, Yasakil, and he belongs to this group. So this is Atul Goel. We are waiting for his presentation. Thank you very much. Join us, say. Thank you very much.
Thank you, Professor Juha.
Please,
And
Atul.
there is no question. It is a big honor for me to be on Juha's show. Juha is one of the most eminent and elegant, technical, high-profile neurosurgeon of the world. And he has led the world into a new dimension of neurosurgery. Without doubt, I go to every meeting. Juha's name is always there. Juha is a renowned, skilled, technical neurosurgeon. And I am very happy to be on his show. Thank you, Juha, for inviting me.
Thank you very much. Please go on with your presentation.
The other person I see on my screen is Bin Zhu, who is also one of my very good friends and good young, and now no longer young, but a very well-known neurosurgeon of the world, known for his dynamic and excellent bypass surgery and various other vascular neurosurgery. But today my plan is to take you to another planet, not to the planet of vascular surgery, not to the planet of tumor surgery, not to the planet of brain surgery, but to a different planet of spine surgery. And I want to give you a different dimension to spine surgery. So I have labeled my title as New Spine Surgery. And I want to introduce this presentation. I want to give the presentation on spine surgery on the basis of my published work. And I want to present what I have said, not what is in the literature. So I am going to introduce a new concept in spine surgery. And that concept is that instability is the issue and stabilization is the treatment. In a number of issues related to spine, the concept is instability is the issue and stabilization is the treatment. I also want to say is that compression is an issue, but not such a great issue. And decompression is almost never an issue. So it is quite a revolutionary concept. And I want to work on this concept. So basically, we must remember that what makes human life is movement. What makes human life's music is movement. And when this movement is disturbed, the music of human life is disturbed. God has given us movement. God has given us movement through our muscles. So we should exercise our muscles, keep our muscles strong, and only if we are healthy, we can enjoy the music of movement. So this is a horse as we see. The movements are on 4 legs. and the muscles of the shoulder and hip are more prominent muscles of a horse and all four-legged animals. The muscles of the spine are not so prominent. Of course, they are prominent, but not so much. The legs and hands, these are strong muscles. The wings of a bird are the strongest. The spinal muscles are not so strong. On the other hand, a human body, where we stand on two legs, the muscles of the spine are strong. Of course, this Usain Bolt, the muscles of hands and legs are both strong and stronger maybe than a horse. But what makes a human body stand on two legs is the muscles of the spine. And we have to keep our muscles strong. So my concept is the entire problem of spine is related to the weakness of the spinal musculature and the neck musculature. So I will work on this concept that if we have not kept our muscles strong due to disuse or abuse or misuse or even injury, we can have various spinal problems. So spinal instability is a problem of vertical spinal position, and vertical facetal instability is the nodal point of problem in spinal spondylotic disease. So this is the concept. Facets are the fulcrum of movement. Disc is not the primary issue in movement. Disc is, of course, an important, which I will discuss later. All the movements of the spine are centered on the facets, like transverse process, the muscles act on the facet. Spinous process, the muscles act on the facet. Anteriorly, the muscles are very few. You see, the longus colli is the only muscle around the disc. So the movements are all focused on the facets, and the spinal fixation at the facet is the strongest form of fixation. For craniovertebral junction, I will first discuss about craniovertebral junction, then I will go to the rest of the spine. Craniovertebral junction muscles are focused on the facets, and facetal fixation is the strongest form of fixation. So this technique of fixation I described in the year 1988. So about 32 years ago, I described this fixation for craniovertebral junction for atlantoaxial fixation. One screw in C1, one screw in C2. And that is my technique, which those who are doing craniovertebral junction surgery know that this is the most fantastic technique of craniovertebral junction stabilization. So when I fuse the atlantoaxial joint, I have three important points. One is open the C1, C2 articulation. Second is remove the articular cartilage. Third is introduce bone graft into the joint and then do fixation. So this is my technique, and many spinal surgeons know about this technique. This was the first case that we did in the year 1988. And now I have more than 3,000 fixation with this technique in my series, more than 3,000. We also described the sectioning of C2 ganglion to open the C1, C2 articulation. And I think this sectioning of C2 ganglion completely provided a window to the atlantoaxial joint and revolutionized this subject of atlantoaxial fixation. I do not do sectioning of C2 ganglion very often these days, but this is what I had described. Basilar invagination was not understood. This problem was not understood 25 years ago or 20 years ago. And this problem was considered to be a fixed problem, and decompression was the treatment. Transoral surgery for this problem and foramen magnum decompression for this type of group B. So we introduced a concept that this is not a fixed anomaly. If the problem is fixed, decompression, remove the odontoid process. If the problem is considered to be fixed, decompress from behind. So this was the concept. We introduced a concept that it is not a fixed anomaly, it is due to instability, due to weakness of the muscles of the craniovertebral junction. And we introduced a brand new concept called craniovertebral junction realignment and stabilization. So no decompression, only stabilization. So this is a very novel concept which we introduced about 20 years ago. And now we have got several patients with this kind of problem. So odontoid is going up. Decompression was the treatment, but now we say open the joint, distract the facet, and do craniovertebral junction realignment and stabilization. So decompression is no treatment. Decompression is a negative treatment. Problem is instability and the treatment is stabilization. This is another case of basilar invagination. Open the joint, distract the facet, and realign the craniovertebral junction. Basilar invagination, open the joint, realign the craniovertebral anomaly. So the treatment is not decompression, stabilization. The problem is not fixed, but the problem is unstable joint due to problem of the muscles of the craniovertebral junction. So this was the first case I did in the year 2000. So 21 years ago, we opened the joint, distracted the facets, and did craniovertebral junction realignment. Otherwise, transoral surgery and decompression was the treatment. So opening of the joint and manipulating of the facet introduced a new treatment for rotatory dislocation. You see, there is a rotatory dislocation, there is a facetal malalignment. There was no treatment for this anomaly. The only treatment that was recommended and that was done throughout the world was decompression. So now we are saying that there is a possibility of treating this problem by opening the joint, manipulating the facet, and realigning the craniovertebral junction. So this treatment I introduced about 20 years ago. And now we have several hundred patients like this. This is a case of trauma injury. You see the facets are in malaligned position. So open the joint, manipulate the facet, and realign the craniovertebral junction. And I have to tell you, for this problem, decompression was the only treatment. Rotatory dislocation, open the joint, and you see you can give a new neck to the person. More than that, the limb weakness, if there are hand weakness, leg weakness, you introduce new power in these patients. There was an entity called fixed atlantoaxial dislocation. So our concept has completely revolutionized this concept. And now I say that there is nothing like fixed atlantoaxial dislocation. All the dislocations can be reduced, and all the dislocations are unstable, and all the dislocations should be treated by atlantoaxial stabilization. You see that in flexion and extension, there is no change in this. So these cases were treated by decompression. But open the joint, reduce and realign the craniovertebral junction and stabilize. Facets are the strongest bones of the body, and introducing screws in C1 and C2 that we described 32 years ago is a very fantastic method of giving new life to these patients. This is fixed anomaly, inflection, extension, no change. Open the joint and realign the craniovertebral junction, one screw in C1, one screw in C2. So the basic issue is that basilar invagination instability is the problem and stabilization is the treatment. Decompression or removal of the bone is which was very common in those days, and even many people do this even today. And I must say, in particularly in Western countries, in United States, most common form of treatment for basilar invagination is decompression. So I have a feeling that this decompression is completely a negative form of treatment. So transoral surgery, which was very common form of treatment about 15 or 20 years ago, I have completely removed this treatment from the face of neurosurgery, and I have made this treatment historical. So the facets are the issue. Facets are the primary point of movement, and facetal stabilization is the treatment of many spinal problems. Lumbar listhesis, lumbosacral listhesis, is a problem of instability. Basilar invagination is also a problem of listhesis of C1 over C2. Problem of instability. So this is listhesis of C1 over C2, and that is basilar invagination. So you see in this slide, there is basilar invagination, there is Chiari malformation, there is syringomalia, there is listhesis of C1 over C2, and the treatment is not decompression of foramen magnum or not transoral surgery, but realigning the craniovertebral junction and the treatment of C1 over C2 listhesis. Then more recently, we introduced another concept, which is absolutely revolutionary concept in the craniovertebral junction and in the spinal surgery. That concept is of central or axial atlantoaxial dislocation. Here you see there is listhesis of C1 over C2. There is atlantodental interval disturbance. There is neural compression, and this listhesis has to be treated by C1, C2 fixation. This concept I introduced about 25 years ago. This is type 1 atlantoaxial dislocation. Now, more recently, about 15 years ago, we introduced that even when there is no atlantodental interval disturbance, even when there is no cord compression, there can be facetal listhesis like C1 going behind the facet of C2. This is an unstable spine, and you need to do atlantoaxial stabilization. There is no rational or no philosophy of doing foramen magnum decompression in such situation. And I must say that foramen magnum decompression is still the most preferred treatment in the world, which I consider to be a negative form of treatment. Another very fantastic or fascinating issue is, even when there is no facetal malalignment, even when there is no atlantodental interval disturbance, even when there is no cord compression, presence of Chiari and presence of syringomalia are indicators of an unstable spine, and they need to be stabilized. Atlantoaxial stabilization is the treatment, and you will find syringomalia disappearing. More important, patient improving remarkably in its clinical symptoms. So there is no question that basilar invagination, Chiari malformation, syringomalia are all secondary to atlantoaxial instability. And I have got several publications, and I wish that those who want to learn more about my concepts should see my publications. I presented 510 cases some years ago on group A, and then group B, basilar invagination. So even when there is no atlantodental interval disturbance, there can be facetal malalignment. In Chiari malformation, you do atlantoaxial stabilization and the syringomyelia will disappear. And the most important and critical and crucial is that the patient will remarkably, not ordinarily, remarkably improve in the clinical symptoms. Even when there is no atlantodental interval disturbance, there is no facetal malalignment, presence of Chiari malformation. We introduced the concept several years ago that there is a tight posterior cranial fossa. This concept was introduced by us, and we had described that foramen magnum decompression should be done. But what I described, I am saying, is not the best treatment. Instability is the problem even when the facets are in alignment, and stabilization is the treatment. This is syringomyelia before operation, and this is syringomyelia after operation. There is no atlantodental interval disturbance. There is facetal malalignment, and atlantoaxial stabilization is the treatment. I have now got several hundred patients where we have done atlantoaxial stabilization without decompression. And you see in the immediate postoperative period, there is reduction in serings, and delayed, there is further reduction of serings. I must say that reduction of serings will not happen in the immediate postoperative period in 100% of patients. It will happen in about 10 or 15% of patients in the immediate postoperative period if the scan is done within a week of surgery. But if you do a scan after about 1 or 2 years after surgery, you will get 100% of cases reduction in the size of serings. So syringostomy, there is no role for syringostomy. There is no role for foramen magnum decompression. There is only a role for stabilization. And we had published several articles on this subject: basilar invagination, syringomyelia, Chiari malformation. Both basilar invagination, syringomyelia, Chiari malformation are brothers. And the father is atlantoaxial dislocation. The father of all problem is atlantoaxial dislocation, and the father is muscle instability, muscle weakness. So muscle instability is the one problem. It leads to atlantoaxial instability, and this father has many children, and those children are basilar invagination, syringomyelia, and Chiari malformation are the major children of atlantoaxial dislocation. And atlantoaxial instability is the cause of Chiari malformation, and atlantoaxial instability is the issue. So we have published recently 388 cases with Chiari 1 malformation, and I do not like to call it malformation. I call it protection. Chiari is a protection and a formation, and it is not a negative. It is not bad. It is good for the patient, and I will show you some more slides. We also talked about pediatric children having Chiari malformation treated by atlantoaxial fixation. And I have to say, without any hesitation, without any doubt, without any issues, that foramen magnum decompression is not a good operation, is a negative form of treatment. So atlantoaxial fixation we have done in several, as I mentioned to you, as I talked to you earlier, that foramen magnum decompression and tight posterior cranial fossa was introduced, a concept was introduced by me. And we have been doing several patients by decompression. And now many of my own patients are coming back, and I am doing atlantoaxial fixation. And I am also getting many patients from around the world where foramen magnum decompression has failed, and I am now doing atlantoaxial fixation. So is Chiari a formation or a malformation? So we have said that Chiari is like an airbag, and when there is a potential or manifest atlantoaxial instability, when there is a potential for accident, Chiari is introduced into the neural foramen and it is not a malformation, it is a formation. So this is a new concept. Cervical fusions are also not primary issues. They are protective responses in presence of atlantoaxial instability. So when you see cervical fusions, do not start doing osteotomies and decompression. They suggest that there is a presence of atlantoaxial instability. Bifid atlas, anterior and posterior arches of atlas, bifid, are also secondary and protective. They divert like this, as shown here, to increase the space in the craniovertebral junction and avoid the compression by the arch of atlas. You see there is bifid arch of atlas. There is bifid, there is no arch seen here. Bifid arch, fusion of the vertebrae, even when there is no compression of the craniovertebral junction, suggest atlantoaxial instability and suggest the need for atlantoaxial stabilization. There is no need for any kind of decompression, no decompression from front, no decompression is obviously not possible from behind because God has decompressed by bifid arch. What one has to do is you have to solve the problem of human being because there is an injury to muscles of the spine and there is an unstable craniovertebral junction and you have to stabilize the atlantoaxial joint. When there is C2-3 fusion, it suggests atlantoaxial instability and it suggests the need for atlantoaxial stabilization. C2-3 fusion with C3 cord compression, there is no need to treat this one. There is a need to treat this father. These are all children, although we had described that you have to fix this also, but now I am saying you treat the father and the children will automatically come in line. You see, there is bifid arch of atlas, there is unstable spine, there is no compression. You don't have to worry about compression and decompression. You will say there is nothing here, I don't need to decompress this, I don't need to treat this. That is absolutely wrong. The problem is of atlantoaxial instability. You see the facetal malalignment. This I call central instability, and the treatment is atlantoaxial stabilization. Os odontoideum, I published this series of 190 cases without even a single complication in the entire series. Now what I am saying is this os odontoideum is also a nature's phenomena. Os is, there is a sectioning of the odontoid process, and God has made this sectioning because of long-standing atlantoaxial instability. The treatment is atlantoaxial instability. I must say that even today, several parts of the world, people are still doing foramen magnum decompression for this and transoral decompression for this and occipitocervical decompression for this. I am saying without doubt, without hesitation, without confusion, that there is only one treatment for this problem is atlantoaxial stabilization. We have to learn this. Os odontoideum, no need for decompression from front or decompression from behind or decompression from below or decompression from above. There is only one treatment, and that is atlantoaxial stabilization. Also, I have to give one more statement that occipital fixation is an absolutely negative form of treatment. When I say negative, I must also say that occipital screws were first introduced by me in the literature in the year 1987, 33 years ago. And I am saying that my technique of occipital screw fixation, I am saying that may not be the best form of atlantoaxial stabilization. Never, never include the occipital bone in your fixation construct, extremely rarely. Syringomyelia is also a natural protective phenomena it indicates the presence of atlantoaxial instability. It is a self-neural destruction and indicates the presence of atlantoaxial instability. So when there is a syringomyelia, look at the spine and you will find atlantoaxial instability, and you have to do stabilization of atlantoaxial joint and not decompression, not syringostomy. There is another revolutionary article of mine where we said that musculoskeletal abnormalities, musculoskeletal changes are due to atlantoaxial instability. Short neck, torticollis, they are indicators of an unstable atlantoaxial joint. You stabilize the atlantoaxial joint and you give straight neck, long neck in the immediate postoperative period. You see torticollis here, there is no need to do any kind of osteotomy or decompression or any such kind of treatment. What is required is atlantoaxial stabilization, and there is a possibility of giving this beautiful smile to the patient in the immediate postoperative period. You see the neck has become straight and the neck has become long, and we have got hundreds of patients where we have done this kind of treatment. You see there is not such a beautiful smile before or even after, but there is a beautiful neck which is long and straight, and that is in the immediate postoperative period. So now what my concept is, that all problems related to basilar invagination like spine fusion, clipper file abnormality, assimilation of atlas, bifid atlas, os odontoideum, platybasia are all musculoskeletal issues secondary to atlantoaxial instability, and neural issues are syringomyelia and Chiari malformation. And all these primary musculoskeletal and neural issues are all secondary to primary problem of atlantoaxial dislocation, and they are all protective in nature. So you see very crooked kind of neck, very bad compression related to basilar invagination. Instability is the problem, and you see the neck is quite straight and beautiful. More important than neck getting straight is remarkable recovery in the neurological symptoms, and this boy has got a new life after surgery. And many people are doing this treatment in whole world, and even in China, I know many friends of mine are doing this kind of treatment. Another thing which is very remarkable and quite revolutionary, you see this patient having marked kyphoscoliosis. The only treatment that you will hear in the world is introducing several screws in the facets and spine and pedicles and putting a long rod in the spine and reducing. But you must know that many of these, a number of these kyphoscoliosis patients, primary problem is not kyphoscoliosis. The primary problem is atlantoaxial instability in a huge number of patients. You do atlantoaxial stabilization and the back becomes straight and the back becomes normal. You see, if you see the literature, this kyphoscoliosis is said to be resulting in breathing disturbances, and in the neurological symptoms, I am saying that absolutely not atlantoaxial instability is the problem, and you can create a new spine after surgery. So atlantoaxial instability can be the cause of spinal alterations and dorsal kyphoscoliosis in a large number of patients. You see, there is dorsal kyphoscoliosis, there is syringomyelia, there is Chiari malformation, there is atlantoaxial instability. Of course, in these patients, you will not even think and do atlantoaxial stabilization. But I will say you start thinking of, even in those cases where there is no syringomyelia, no Chiari malformation, the kyphoscoliosis is almost always a result of central or axial atlantoaxial instability, and you need to do stabilization. So this kind of kyphoscoliosis, which you see often, the treatment is not osteotomy, is not screwing of the spine. Do you know what is, screwing of spine can mean huge number of screws and huge number of rods, and which is, I consider, a negative form of treatment, and you can never bring this kind of smile in these children. So in short, long, short neck, torticollis, kyphoscoliosis, if you want to make your patient a king, this child a king, and if you want to bring this kind of divine smile in your patient, and if you want to bring this kind of smile in your own doctor, you see, and this kind of power in your hands, the only power is learn the operation of atlantoaxial stabilization. And John will agree that you can make your patients king, and you can yourself become a king if you learn the art. John, are you listening? I'm not sure John is
Oh yeah, I'm listening, but I don't deserve to be in the OR.
So John, your doctor, your king is here, and your patients have become this king smile, and you will appreciate that king smile. This question of central or axial instability is here to stay. And many of our patients, several, you will not imagine how many patients have central atlantoaxial dislocations which are not diagnosed and not treated and ill-treated. There is no compression of the craniovertebral junction, and this patient has been treated by atlantoaxial stabilization on various telltale evidences, like bifid can be an evidence, syringomyelia can be an evidence, and several other things which I have published on several occasions. You see, this patient has no atlantoaxial instability, no compression, and no facetal malalignment. There is a central atlantoaxial instability diagnosed on the basis of cervical kyphoscoliosis, and I can say that this young lady has got a new life in the immediate postoperative period. You see, the hands were not even going up, and the shoulder was drooping, and now the shoulder has come up in the immediate postoperative. So you have made this person a king, and king of sorts. There is no question. Hirayama disease in Japan and in China, very common. This kind of patients were treated in a very different kinds of treatment. And I have realized, and I have published, that this problem is of instability, and you can give new life to these patients in the immediate postoperative period. So foramen magnum decompression, can it become historical? Absolutely. Now I want to turn to next chapter of my presentation, and that is cervical and lumbar spine. I have written on several occasions on anterior approaches to cervical spondylosis. This was published in Sweet and Smidek book on anterior approaches to cervical spine. You see multi-level degeneration, you do decompression and anterior. So I had published and I had presented on several occasions. So anterior surgery for cervical spine is a very common form of surgery. Today I have to say, like transoral surgery is completely historical for many people in India and in China and various parts of the world. And I have got several people in China who follow my concepts and agree to my concepts. Today I am saying in Juha's lecture series that this anterior cervical surgery is going to become historical. All forms of anterior cervical discoidectomy and anterior corpectomy are soon going to become historical. So all those listening to my lecture, you better listen properly what I am saying and what message I am going to give. I have to tell you that this anterior surgery is a very common form of treatment, like osteophyte removal, disc removal, this You see osteophyte removal. This is for my own chapter, which I have written for Schuit and Smedek book. And as I have mentioned that anterior surgery was very commonly done by me, I had introduced this tricortical screws with plate and standalone tricortical screws. I had introduced 1 screw, 2 screw, 3 screws. So this was my own technique, which I am saying now is going to become historical. And I am going to introduce to you a revolution, an absolute revolution in spine surgery. And I want you to listen to me properly. The entire spine surgery is disc oriented. And the major sentence that is written in the treatment of spondylosis is that the disc is a problem. Disc herniation is the problem. Disc space reduction or reduction in water content of the disc is the primary issue in spinal degeneration. I have to tell you that disc is never or not the problem. Disc is divine. Disc is God. Disc can never be a problem. You see, this is the spine. This is the human spine. All the movements are focused on the facets. All the muscles of the spine are behind. The muscles attached to the spinous process act on the facets. Muscles acting on the transverse process act on the facets. All the movements are focused on the facet. And the facets are the fulcrum of spinous movement or spinal movement. You see, this is the fulcrum and all the movements are on the facets. Disc is divine. There are hardly any muscles attached or acting on the disc. Longus colli muscle is the only muscle which is like a curtain. I say that disc is like opera conductor. Disc conducts all the movements. But there is not one instrument in hand in the opera conductor. Disc is the center of weight bearing. You see, disc is like air in your car tire. Your car will not be able to run if there is no air in your tire. And that air in your car tire is the disc. Disc regulates all the movements. Disc is the center of weight bearing. You are standing and you are weightless because of your disc. You are standing and weightless. Your brain is weightless because of CSF, because of fluid. Same thing is that this fluid in your spine or in your disc, it makes you weightless. All your activity, the muscles acts on your facets. Facetal instability or vertical facet. When the standing human position, these muscles become weak. You have not made your muscles strong. The facetal instability or vertical spinal instability is the issue. You will be surprised to know that craniovertebral junction instability or degeneration has never been discussed in the literature. So this was my first article I discussed 20 years ago on craniovertebral junction instability due to degenerative osteoarthritis. So atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common instability of your spine. Degeneration of atlantoaxial joint, which is never discussed in the literature, is the most common form of spinal degeneration. When we talk of spinal degeneration, we always talk of C5, C6. We talk of C6, 7. We talk sometimes of C4, 5, and very rarely on C3, 4. We never talk of C1, C2 degeneration, which is the most common form of spinal degeneration. I want to discuss this with you. You see reduction in the atlantoaxial joint space. You see reduction. This buckling of the posterior longitudinal ligament. This osteophyte formation. I am saying that these are not primary problems. These are related to atlantoaxial instability or atlantoaxial degeneration. So when there is atlantoaxial spine degeneration or craniovertebral junction degeneration, there is instability of the atlantoaxial joint, which results in reduction in the joint space, which results in buckling. This is not primary, buckling. And when there is buckling of the posterior longitudinal ligament, there will be osteophyte formation here. You must realize that osteophyte formation is not only in the midline, it is also in the vicinity of the facets. And these osteophytes are not primary problems. They do not need to be removed. The problem is unstable atlantoaxial joint, and you have to stable the atlantoaxial joint, stabilize it. So osteophytes, I want to give a very golden and revolutionary sentence for you. When you see disc space reduction in the subaxial spine, it indicates spinal instability. When you see osteophyte formation, it indicates spinal instability. When you see abnormal bone formation, it indicates spinal instability. These statements are not discussed ever in the literature. You must remember this. Never it has been discussed. So there is an ossification in the region of apical ligament in the vicinity of the C2 body and odontoid process. There is ossification here. These are not primary problem. There is no need to do decompression. There is no need to remove this bone. It is not compression which is the problem. It is an unstable atlantoaxial joint and it needs to be stabilized. So decompression is not the treatment. These are indicators. These are not primary. These are indicators of an unstable atlantoaxial joint. Retroodontoid pseudotumor or retroodontoid osteophytes. I must tell you, the whole world was doing transoral surgery to remove these osteophytes. Whole world, not one person in the world was not doing this. Some people then described lateral approach. Some people describe endoscope to remove this. But this article of mine, which was published about 20 years ago in Japanese Journal of Neurosurgery, where we said that these are osteophytes of the atlantoaxial joint. They are not primary problems. They indicate atlantoaxial instability, and they are evidences of atlantoaxial instability, and you need to do craniovertebral or atlantoaxial stabilization and decompression either from front or from behind. This compression is not the problem. Compression is not the issue, and decompression is not the treatment. Stabilization is the treatment. So in the year 2004, I published 2 cases in Japanese Journal of Neurosurgery, and this was the first time in the literature where instability was identified to be the cause of retroodontoid mass, and stabilization was recognized as the treatment. And now many people in the world are doing this treatment. Retroodontoid cyst. You can easily come and remove this cyst, but that is not a rational form of treatment. These are indicators of unstable spine. There is a possibility of immediate postoperative disappearance of retroodontoid pseudotumor. They are indicators of an unstable atlantoaxial joint, and they need stabilization. You see, there is a huge cyst, but there is quite a bit of unstable spine. You stabilize. I have not touched this disc, and this disc has disappeared in the postoperative period. So this is a protective, natural protective phenomenon. This cyst is very easy to remove. Puncture the cyst and matter is closed, but that is not a correct form of treatment. That is going against the laws of nature. What is required is atlantoaxial stabilization. Retroodontoid pannus. I must tell you, the whole world was removing this pannus by transoral surgery and removal. This compression is the problem. Compression is the problem. Decompression is the treatment. Absolutely no. This buckling of the ligament is an evidence of an unstable atlantoaxial joint, and I stabilized it, and there is immediate regression of pannus. So what I'm saying is pannus is not a primary problem in rheumatoid disease. Pannus is secondary to atlantoaxial instability, and I have written this on multiple occasions about the pannus and presence of retroodontoid soft tissue enlargement and retroodontoid tumor as an evidence. If you don't see anything else, retroodontoid pseudotumor is an evidence of an unstable atlantoaxial joint, and you need to stabilize it. So we had introduced these spacers, this inside the atlantoaxial joint, which are now very commonly done even in China. And these spacers I had introduced about 20 years ago or even more, and these are now becoming very important form of stabilization of the atlantoaxial joint. I want to talk about facets. If you see this is the facet of cervical spine. This is C3 vertebra. You see the size of the facet? It is bigger than the size of the vertebral body. And if you hold in your hand, this is the strongest bone of the body. I must tell you that the facets have not been used for stabilization by neurosurgeons or by spinal surgeons or by orthopedic surgeons because we like to come from front and we like to remove the body, which is a very weak part of the human vertebra, very weak. We want to exploit the weakness. We are afraid of the strong part of the spine, which is the facets. Facets are the strongest part of the vertebral body. Like I said about listhesis of C1 over C2, I am saying that spinal problems or spinal degeneration, the problem is listhesis of the spinal facets, C5 over C6 or C4 over C5. This is the problem. Disc is not the issue. You see this reduction in the joint space, bulging of the disc, osteophyte formation, multiple level disc bulges are not the problem. They are not primary issues. They are secondary to spinal instability. And believe me, my friend, I want to make this statement in Juha symposium in front of you, and this will form a revolution in spine surgery. There is no need to disturb this degeneration. This is not disc degeneration, this is secondary to primary problem of spinal instability. Osteophyte formation is not a primary process. You don't have to come from front and remove this osteophyte. You don't have to come from front of the neck and remove these osteophytes. This is not primary. These are indicators of spinal instability. So vertical fascial instability is the nodal point of spinal degeneration. So what we did is about 15 years ago, we described this concept that do not remove the osteophyte, distract the facet using these spacers, which I described. I call them Goel facet spacers, which are my patented product. Open the facet, distract the facet, the ligament, this osteophyte will disappear, the ligamentum flavum bulging will disappear, and you will get remarkable clinical recovery. So I described these facets some 15 years ago. You see this ligamentum flavum buckling, the posterior osteophyte, ligamentum osteophyte formation, and posterior longitudinal ligament buckling. You distract the facets, multiple level distraction, multiple level instability. Basically, there is an unstable spine. You stabilize, distract by facet distractors, and you find remarkable recovery, and you find new disc formation, new space in the disc. You see here, you compare, this is posterior osteophyte, you see new disc formation, and this is stabilized by facet distraction technique. There is disc bulging here. There is new disc formation. Ligamentum flavum is unbuckled. This posterior longitudinal ligament is unbuckled. And I have treated by multi-segmental. This is different patient. And you see the neck movements they remain. So this is the multi-level facetal distraction. And you see, basically, the concept is instability is the issue and stabilization is the treatment. And initially, in the early part of my journey with this, I used to do facetal spacers as treatment. So I have treated many, many patients with this kind of facetal distraction using spacers, and ultimately my issue was arthrodesis or fusion. You see, these are osteophytes, and now there is a new disc formation and the compression is disappeared in the immediate postoperative period. This is preoperative scan, and I have done this kind of facetal distraction. You see, there is the compression has gone, and there is fusion in the joint in the affected vertebra. This is of OPLL, which I use. I will talk about OPLL later. I treated with multi-level facetal distraction. So this is multi-level facetal distraction using spacers. So this is large osteophyte. You see, this is large osteophyte in the preoperative, postoperative disappear, new disc formation, and this is after 2 years, and ultimately it leads to fusion. So you see, there is multi-level fusion, there is no decompression. In short, I am saying that for spinal degeneration, there is no need to remove the disc, there is no need to remove the osteophyte, there is no need to remove the lamina, there is no need to touch the spinal cord or spinal root. Then there is a need to do fusion by distraction arthrodesis. So here is a small video which I will show you. You carefully see this. This was the facetal distraction technique which I used to do earlier. I must say that this is in my history now. I will go further, and how I improved, I will talk to you about that later. You see, this is a very simple technique, and even your junior most resident can do it very quickly. There is no need to do corpectomy, no need to do osteotomy, no need to remove osteophyte. I am now saying that osteophytes are protective. Osteophytes on, you see, such a short operation, you can do in 10 minutes. And I do many of these cases. I just want to, because we don't have time to do this, and I don't want to spend too much time on this, and you give remarkable stability to the spine by this technique. You see, this is the osteophyte, new disc formation. The osteophyte has disappeared, and there is multi-level spinal fixation. Because these patients will talk in my own Indian language, in my own national language, you will not understand. So I will not like to discuss to show you videos. You see, this is the osteophyte, this is post-operative, and there is a video here. And this patient has a beautiful smile. His wife has a beautiful smile. And what I have done is only stabilization, no decompression. So this was a concept. This was a concept that how that decompression can be avoided. Spacers were like atlantoaxial spacers, like joint jamming technique. I introduced these cervical spacers. Facet distraction as a treatment for single and multi-level. I introduced this concept about 10 or 11 years ago, but of course my experience is about 15 years ago, where this was published as Journal of Neurosurgery cover page. So we introduced a new concept. Concept was an unstable spine is the issue. Osteophytes are not the problem. Disc is not the problem. Ligamentum flavum buckling is not the problem. And compression is not the problem. We studied several anatomical studies were conducted, and we introduced these intra-articular spacers for cervical spine and for lumbar spine. And these are very heavily patent in all over the world, in United States, in Europe, in India, and in various countries. And in India, there are 21 patents of mine on this subject. So I will show you another thing. You see, there is a disc herniation. This disc herniation, the whole world will come from front and remove this disc. There is no other treatment. But I treated this by fascial distraction, and this disc has reversed in the immediate postoperative period. The disc has gone inside. You see this kind of chronic disc, and this is immediate postoperative reduction of the disc. And I will say, of course, I will talk more about this later and what is my current concept of this treatment. This is from my historical. This was what I used to do 15 years ago. And there is no discoidectomy. There is only fascial distraction. And you see the treatment is here. And these are very heavily published. Same concept I use for lumbar spine. For lumbar spine, there is no need for decompression, no need to remove this multi-level disc and multi-level osteophyte and fascial. What is required is decompression, no decompression, only fixation using, this was my historical form of treatment, which I published in Journal of Neurosurgery about 10 or 12 years ago, lumbar canal stenosis treatment by fascial distraction. And I will discuss my current treatment with you very soon. And we discussed, we identified the anatomy of facets and how the facets are affected. And I even introduced my daughter into the subject of neurosurgery. So the concept was that radiculopathy, lumbar and cervical, is not due to compression, it is due to an unstable spine. Atrophy of cord is not due to compression, but it is due to instability. Decompression is not the treatment, but stabilization is the treatment. The whole world, the concept in spine surgery is that decompression of the compressed or deformed neural structure is the basis of surgical treatment for several decades or maybe for a century. But what I'm saying is decompression is not the treatment. Decompression is negative form of treatment. Removal of the disc, removal of osteophyte, decompression from behind, laminectomy, laminoplasty are negative form of spinal treatment. In the year 2013, so about 7, 8, 10 years ago, I introduced another concept for cervical spondylosis, that only fixation, not even distraction by spacers, not even distraction, is the treatment of cervical spondylosis. And more recently, I published this article. You just read this title, that muscle weakness related spinal instability is the cause of cervical spinal degeneration. And spinal stabilization is the treatment. So this article was published in World Neurosurgery, my experience with 215 cases. And I want you to read my article. And I want you to read my article. And I have written in this article that 100% of my patients have recovered. And if you read the literature on anterior cervical corpectomy and anterior cervical degeneration, there are complication rates extending up till 50% in multi-level spinal decompression. And in my article, you must read that 100% recovery in symptoms. 100% is not an arbitrary figure which I am giving. When I say 100%, I have got legal implications when I say 100%. Suppose one of my patients has not recovered, he can sue me with my statement. But I am saying that no, not a single patient of mine has not improved following multi-level, only stabilization and no decompression. You see, there are multi-level, 2-level compression. The whole world will do anterior decompression or posterior decompression, and that is a very well-defined form of treatment. And I have done only stabilization from behind. And there are 2-level compression here, but I have done 4-level fixation because during operation, I identified additional levels of unstable spine. You see, you do this fixation and then this upper level, then you say adjacent level has become now weak. Now I will do adjacent segment. It is not adjacent levels instability that has come later. It is an instability that you have missed. And this should have been fixed at that level. And you see, I am not sure if you will understand my Indian language, but this lady is the happiest lady. And even many Indian people will not understand because this is local Maharashtrian language. And what she is saying that her hands have improved, her legs have improved, and essentially she has got a new life. I am saying a new life. And you please try to understand. You see, this is a single level compression. The whole world will come and decompress. They will remove this disc, they will remove this osteophyte, and they will remove what I have done. And this is after some years. You see, I have done only stabilization and no decompression. This is multi-level osteophytes. This is osteophyte, which is a divine, which is protective, which is fantastic. It is not a compressive factor. You see, I have done stabilization. I have achieved arthrodesis. This osteophyte compression is spontaneously disappeared. And you see this patient, if you see, of course, you will not understand his language. If he's talking in Chinese, you might understand Japanese, but you see, this boy was not able to even stand before operation. And this is in the very early post-operative phase. Unfortunately, I cannot, translate for you. This is a compression, single level compression. I did fixation at 2 levels. You will say, why 2 levels? Because during operation, you can see the facet, you can rock the spinous process and see unstable, and you give a new life to this person. This is multi-level cord compression. The whole world will do multi-level corpectomy or discoidectomy or osteophytectomy, or some people will do laminectomy, which is still considered to be gold standard. You see, I've done multi-level only fixation. You see, the osteophytes have disappeared. The compression has disappeared. And I have to tell you, in Juha symposium, I'm giving you this, announcing this, that this is the treatment. Facetal fixation is the treatment for spinal degeneration. And decompression is a negative form of treatment. So spinal degeneration, this is very heavily published now by me, and you must see that instability is the cause of symptoms. Compression is not the cause of symptoms, and stabilization is the treatment. Decompression is a negative form of treatment. It is not neural deformation or compression, but instability is the cause of symptoms in degenerative spinal disease. Camillus technique, this transarticular technique, is the most beautiful and the strongest and the easiest. There is no technique as easy as this. You do anterior fixation using implants and all. You can do 1 or 2 level. ACDF is a very commonly done procedure. But this technique can be done by not by your residents, by your junior residents, but your nurses also can do this technique. Even I will say my ward boys can do this technique. It is so simple technique, and you can introduce 2 screws, you can introduce 3 screws, and you can give a very solid stabilization. So this is an underused technique. Most important is not the technique. Most important is not how you do it. Most important is how you understand it. What are your concepts? Most important is to identify which spinal levels are unstable and do stabilization of those levels. You see, these are 2-level fixed, 2-level instability that you have. These are indicators of unstable spine. But you can do during operation, you can maneuver the spinous process and identify some additional levels of instability. And you see the osteophytes which were here have disappeared after some years, and there is a complete bony arthrodesis. What is required is not decompression. What is required is stabilization. These are nature's protection These are secondary. Ligamentum flavum buckling is secondary, not a primary process. They are indicators of an unstable spine. You see, there are multi-level osteophytes. Don't come and remove this. They should not be removed. You do stabilization and you see the arthrodesis already forming, bone fusion, and you see the osteophytes have disappeared. This compression has disappeared. What you need to do is to do stabilization. So you can do single level, single screw stabilization, or you can introduce 2 screws, which I have described, this double insurance technique of stabilization. This osteophyte has disappeared in quick time, and only stabilization is the treatment. This ligamentum flavum buckling, osteophyte formation, you do only stabilization, no decompression, and you see these osteophytes have disappeared. And you have to believe me, my friends, and you have to read my publications. I am saying 100% magical recovery in your symptoms. And I will just show you how quickly and how rapidly I do this. And I can tell you this is the easiest technique of spine. You do multi-level anterior corpectomy. This is the midline, this is anterior, this is posterior. You can do this in quick time. You can also see, I'm not able to show you. You see, this is, my operation does not involve any kind of coagulation. You see, I am just rapidly going to show you, this is the entire operation actually. And you see how the joints are open. You see the facets are open. Okay? And this is the stabilization. This is, I have done transarticular. This, of course, this fumes should not come. These fumes are not good. You have to irrigate. You see how much the joint is unstable. Of course, this operation, the multi-5-level fixation can be done in 20 minutes. If you come from the cervical spine, you do 10 hours of fixation and you can hit the recurrent laryngeal nerve, you can hit for OPLL, you can hit the cord, you drilling for hours and hours. You see this, and you see the fumes because the bone is so strong. You see the screw has been fixed and you can see the stability, which is a solid rock-like stability. No stability can be more stronger than this. Only fixation. So you see this patient has undergone 4-level fixation and you see this compression has disappeared over the period of time. More importantly, remarkable recovery in the symptoms. So my concept, which I want to give to you, is that instability is the cause of spinal degeneration. Instability is the cause of symptoms and stabilization is the treatment. Sorry for this, it has come again. Now I want to give you another fantastic revolutionary concept, that atlantoaxial instability is very commonly associated with multi-level cervical degeneration. Atlantoaxial instability is commonly associated. You see this multi-level degeneration? There is no compression here, no compression. But there is unstable atlantoaxial joint. You have to do atlantoaxial stabilization. You have to do only stabilization. So subaxial plus atlantoaxial stabilization. So role of spinal and atlantoaxial instability in cervical spondylotic disease. And believe me, you can create a revolution in spine surgery and you can create a revolution in patient's life after surgery. Multi-level spinal degeneration, there is atlantoaxial instability as well. So there is atlantoaxial stabilization, subaxial stabilization. Unfortunately, the language is not in, you may not be able to understand what he's saying. But this guy is saying that his life has changed and has got a new life now. When there is severe myelopathy symptoms, when there is severe myelopathy related to cervical spondylosis, atlantoaxial instability is always there, almost always there. You see, there is multi-level with severe degeneration. There is atlantoaxial instability. So there is multi-level in severe. You must read my article. I'm giving you the title of my publication on this forum. You must go back, those who are interested and those who believe in this concept. You believe, whether you believe or not, that is on you, whether you want to agree or whether you want to become high. If I know I don't agree or don't agree, who bothers about you, whether you don't agree or don't agree? But my patients will vouch for me. My patient will say, yes, I agree with you. And without hesitation, I am saying that you don't agree today, but tomorrow you have to agree. Day after tomorrow, you have to agree. And if after 6 months or 1 year do not agree, then you better don't agree. You do whatever you have to do. When there is, you can use alternative technique of atlantoaxial stabilization. You see, there are multi-level. This patient came with severe problems, and this patient was not able to walk before operation, I think. You see, I don't remember many of these patients. You see, this patient was not able to walk. And now you say, no, I don't agree. I want to do decompression or not. You should not. I'm not saying you agree right away. But those, I have got more than several hundred fellows from all over the world who have come to me. And you see how this person has got a new life. You do decompression and decompression from front and decompression from behind. You will never be able to get this kind of recovery. You see this multi-level cord compression, no decompression. Of course, I cannot show you many of these pictures, but you see this patient, how he was walking before operation. He was maybe not able to walk only. You see how he was able to, he used somebody's help to walk, and now you see how he's jumping around. You have never seen such recovery in spinal degeneration surgery. You see this multi-level, I have done only fixation, and you see how this person is now walking. He was not able to even stand before operation. Unfortunately, this language is not of yours. He was not able to stand before operation, and now he's talking like this. You see, you can use 2 screws, you do multi-level stabilization, osteophytes will disappear, and you get a new life. You see this compression, no need for doing anterior cervical decompression. I am saying ACDS surgery is a negative surgery. Anterior decompression is a negative form of treatment. You do only stabilization and you see the wonders in treatment. So now I have got several. Now many of these patients which I am now doing is, you see patients have already done, many doctors have done anterior cervical ACDF fixation. This patient comes to me after severe neurological deficit. There is no cord compression. No cord compression. You see, I see unstable atlantoaxial joint. I introduce atlantoaxial stabilization and I give him new life. You see, I have published this article. You must read this following C3 to interbody fixation. I do atlantoaxial stabilization and give new life to this person. You see this anterior fusion. There is little bit compression here, but what is the issue is atlantoaxial central instability, which is ignored by, you see, on a wheelchair, not able to stand, not able, this patient, what you will do? You come again to an decompression from here. I think this decompression is a negative form of treatment. You must, you remove this word. You see this in the immediate post-operative, a person who was on wheelchair. And I have got several patients like this who have, you see the smile on the person, of the accompanying person. And now this gentleman is walking. Same concept I have used for lumbar canal stenosis. Lumbar canal stenosis, you see this was published in Neurosurgical Focus. The title is Role of Stabilization and Futility of Decompression. No decompression. You see lumbar canal stenosis, if you read the articles, laminectomy, endoscopic laminectomy, decompression, multi-level decompression, I am saying that only stabilization is the treatment. And this article was published in Neurosurgical Focus. The whole world will do decompression and you have to agree to it. And I am saying just do this fixation and you see the magic, and you will see the magic in the immediate post-operative period. This multi-level, no need for decompression. These are indicators, these bulges are indicators of unstable spine. If you see the literature, the whole world is saying that these are stable and decompression is only treatment. I am saying, you will say, I don't agree with you. Dr. Goel, I don't agree. You please don't agree. Who is saying you agree? But you will agree to this tomorrow. And you will agree 110% if you come and make a visit to my department and stay in my department for 10 days, you will say, Dr. Goel, I agree with you. But this concept is here to stay. I have operated on president of another country with this concept. You must remember, with complete cure of the problem. No need for decompression in such issues. What is required is stabilization, and what is required is multi-level stabilization using transarticular screws using Camillus technique. So this is another patient I will show you. I'm not sure if you can understand this language, but you understand, you see his poise, you see his confidence, and you see the beauty with which he's telling you that he is completely cured of his problem from immediate post-op. And you see the pride in this doctor's face. You see how proudly his, and you see the smile has now come, beautiful smile has come. And this smile you have never seen in spinal patients. You will always say you will never have relief of pain to a complete extent. You have impartial, yes, doctor, I'm a little bit better because you have fused, you have sutured all the muscles, you have stabilized. But this kind of smile in the doctor's face and patient face, you have never seen in lumbar canal stenosis patients. And I have got several publications on this, and you can introduce 2 screws, you can introduce 3 screws in one level. And this technique has been very heavily published. Now this another thing which I'm not sure, I know many of you are not spine surgeons, and in China I was told by Juha that many orthopedic people do this treatment of this kind of scoliosis, and they treat by orthopedic ways. And the orthopedic way is, scoliosis treatment and multi-level issues, and decompression is a key word in spine surgery. Decompression, this is problem related to spinal instability, and spinal stabilization is the treatment. So this patient, deformity, no need for bone removal, no need for kyphectomy or all those things. So I introduce you a concept. Is it necessary to resect osteophyte in degenerative cervical spondylosis or lumbar spondylosis? Answer this question. I want to answer this question by saying that removal of osteophyte, which the whole world of spine surgery is doing, the whole spine surgery is based on the concept of removal of osteophytes. I am saying osteophyte removal is not necessary. And recently I published this outcome of only fixation as treatment and what happens to osteophyte in several cases which I showed in this article. And you must read this article of mine where I'm saying that osteophyte resection is not necessary. This was published in World Neurosurgery. Spinal stenosis. You see, when you call spinal stenosis means compression, means when there is compression, you need to decompress. When you say lumbar canal stenosis, you need to decompress. When you talk of cervical canal, hello, Juha, some interruption is there?
I got it.
Okay. When you talk of lumbar canal stenosis, when you talk of cervical canal stenosis, it means you need to decompress. I am saying this term is very bad term. You don't call it stenosis, because that gives you stenosis means decompression. I am saying you call it multi-level spinal instability. This kind of kyphosis, you see kyphosis, if you read spinal literature, even recent article in Journal of Neurosurgery, the treatment is to remove all these bones or kyphectomy, which is a very nonsensical form of treatment according to me. I should not use such words, but I want to use these words because I want to give a strong message that this kyphosis is a result of multi-level instability. And this kyphosis needs stabilization and only stabilization. When you find atlantoaxial instability, you do only atlantoaxial stabilization. When there is no atlantoaxial instability, there can be central atlantoaxial instability. Compression is nothing. If you don't see compression, does not mean that this is not unstable. It needs stabilization. You form a C like this, the entire C needs to be stabilized. There is no need to remove any single bone from front or behind. So these kind of kyphosis, no need for kyphectomy or removal of the bone. It needs stabilization and it needs posterior stabilization. So I have got several patients where I have done and I have given new life to these patients. Another, probably a controversial concept. I am still working on it. I don't want to say for sure. I don't want you to take home this message. But I am saying for prolapsed herniated disc or extruded disc, there is no need to remove the disc. There is no need to do discoidectomy. And I have published this. This is on the basis of publications. When there is a disc herniation, the whole world will do ACDF. I am saying this disc herniation is a result of an unstable spine. When the spine becomes unstable, the disc herniates. I am saying if you have injured your spine by heavy weightlifting, you have injured your spine, you have made it unstable, and that is why the disc has herniated. That is why when you wear a lumbar belt or a cervical collar, your pain gets relieved because unstable. Instability is the issue. This is my answer. So I have done only stabilization. I have not removed this disc. And you see the disc has disappeared after 2 months of surgery and there is complete, the disc has, herniation has gone. So what I'm saying is, instability is either the cause of disc herniation. Instability either leads to disc herniation or disc herniation leads to instability, and you need to stabilize those segments and you do not need to do anything to the disc which will automatically disappear. So you must read this article of mine in World Neurosurgery, where we have said that cervical radiculopathy or disc herniation, only fixation is the treatment and there is no need to remove the disc. And same concept for lumbar disc. The whole world will still come and remove this disc. Huge compression by the disc, and you see the disc has disappeared after a few months and there is no removal of the disc and there is only stabilization. And this is one level disc. I identified that there is ligamentum flavum buckling. This segment is also unstable. I stabilized 2 segments. No discoidectomy. You see here, there is a disc herniation and there is complete disappearance. There is a huge disc herniation and there is complete disappearance. So these are revolutionary concepts. These are different concepts. This can change the game. I am sure, I'm sorry to say, but 100% people watching my show here on Juha's show will say that I will do discoidectomy. I will not do what you are saying. You please don't do. But if you don't do, you are a thinking neurosurgeon. You have come to neurosurgery because you think and work. If your thinking goes beyond my concept, you please come and visit me. Or you read my articles on this subject. You see, this is another case of disc herniation. Nothing was done to the disc, and this is a fusion, and this herniation has disappeared. Now I've got several, whether you agree or not agree, that is your personal issue. I have not, I don't operate because I have to make you agree or make you happy. I have to do because I want to make my patient happy and patient strong and patient magically happy, not ordinarily happy, magically happy. John, you just see there is some trouble. Yeah, I can, some noise is coming. Please.
John, you just see there is some trouble. I can, some noise is coming. John, you just
And-
see there is some trouble. I can, some noise is coming. John, you just see there is some trouble. I can, some noise is coming.
John. Okay now, John?
Yes, yes.
These concepts are so revolutionary, John, that even your system starts shaking. Your whole system, even John starts shaking. And you see this disc, John, the whole world will remove this disc by discoidectomy. I am saying don't have to touch this beautiful divine disc. You just stabilize and this disc will disappear and you will find immediate post-operative remarkable recovery. So this is, I'm not saying whatever I'm saying, whatever sentences I'm saying are all published and very heavily published in literature. Sometimes you see the title, cervical instability can cause lumbar canal stenosis. You see this patient came with symptoms of cervical spondylosis with lumbar canal stenosis symptoms and some problem in the fingers. I stabilized the spine and his lumbar symptoms also disappeared. Now I want to introduce another magical concept in spine surgery. Magical, absolutely magical and revolutionary. Ossification of spine, ossification of posterior longitudinal ligament and cervical spondylosis, same cause and same treatment, and cause is instability and stabilization is the treatment. You see ossification of multi-problem ossification of the posterior longitudinal ligament can be of various kinds. And the treatment described for ossification of posterior longitudinal ligament is decompression from front or decompression from behind. Some people say if there are short segment, you decompress from front. If there are long segments, you decompress from behind. So decompression, laminectomy, laminoplasty, corpectomy. There are about 500 forms of treatment for OPLL. I am saying on Juha's forum today that OPLL, you see, before I say that, I must say that I also used to do corpectomy, and I described this oblique corpectomy for the first time in the literature. Many people are doing oblique corpectomies. So what I described is I did oblique corpectomies like this, and you see the oblique corpectomies and did decompression. I used to do decompression myself and I described, and I was very good at it. But now I am saying, and you read this beautiful sentence, Atlantoaxial instability can be cause of OPLL. Atlantoaxial instability. You see, when there is OPLL like this, I am saying that do not do decompression. I am saying you just stabilize this spine by this very simple technique and you see the magic. I described this technique of only stabilization for OPLL several years ago. This was published about 7-8 years ago. And more recently, I described my experience with 52 cases with only spinal fixation, no decompression. And I can only tell you, my dear friends, you please agree to this and don't start decompressing because you can have a disaster if you do multi-level decompression from corpectomies from front. You can create quadriplegia, and those who are doing OPLL surgery know that some of their patients can get quadriplegia or worsening. So these are OPLL, which I have treated by multi-level. This is multi-level OPLL. You see huge OPLL I have done with only fixation. You see spinous processes I have not removed. This is multi-level OPLL, and I have not done any decompression. I will like to show you. You see this patient. You see this patient is saying that there was a fantastic smile. You see, I cannot now, you have to see the smile and you have to agree with what I'm saying. Multi-level. And there is no point in arguing with me. You see, you argue with me on phone or on, there is no point in arguing with me. Now these patients will answer your argument. This is patient has come during Corona times. He was not able to even sit before operation. He was not, he had come on a, not even, he was brought on a stretcher. So now, you know, these are, I have published this with multiple papers. So I am saying this Camillus technique is wonderful. I have modified this technique as double insurance, 2 screws you can do. And I have done, so atlantoaxial and subaxial cervical spinal fixation, can it revolutionize cervical surgical treatment of cervical myelopathy related to OPLL? I am saying yes, and 100% yes, and without confusion. So now, before I wrap up my show, not my show, Juha's show, can decompressive laminectomy, decompressive corpectomy, discoidectomy, osteophyte removal for degenerative lumbar and cervical stenosis become historical? Yes. Is instability the nodal point of pathogenesis of both cervical lumbar myelopathy? I'm saying yes. So I am introducing a concept. Like I said, that transoral surgery will disappear. I said this 25 years ago. Today, there are still people don't agree with me. Today, people say, Dr. Goel, I don't agree, I do decompression. You please go ahead and do decompression. But many people agree with me, they don't do transoral surgery. Like many people still do posterior foramen magnum decompression. I said 15 years ago that foramen magnum decompression is a negative operation. Many people do not agree still, but some people agree with me. I am saying today that cervical anterior surgery, ACDF, corpectomy will disappear into the history books. None of you agree with me. I know many of you don't agree. I know there are some people in the audience who agree with me, and I will identify those people after the lecture. But I am sure that all these techniques, all this instrumentation, posterior laminoplasty, laminectomy will disappear into books of history. From only decompression to only fixation, this is a century-long treatment journey of cervical and lumbar degeneration, and this journey has been introduced by Dr. Atul Goel in front of you today. Completely revolutionized the treatment. Now these concepts, compression is never primary. Decompression is never the treatment. Very huge, revolutionizing statements. And this is a card which my patient sent me. Recently, I had done this kind of fixation. Spine, the was shine bright. She changed it to spine bright. So thank you, my dear friends. I hope you enjoyed it, and I hope you learned from it a different perspective. I am sure you will change, my dear friends, sooner than later. And John has also changed. In the meantime, so Juha, over to you. Juha, I hope you enjoyed. I know Juha is a fine microvascular neurosurgeon. He's a king of aneurysm surgery, absolute revolutionizing his techniques. But even Juha will give me a smile today. Juha, over to you.
Thank you very much, Atul. It was a splendid lecture. There are very few people in the world who can change the world, and you certainly did. I was in the mid-80s, I was in London, and I saw Professor Alan Crockett to do transoral surgery. And yeah, I should have come to you. I should have come to you to learn from you, because I have done all those operations, what you mentioned, 1,000 cervical operations and maybe 400 spinal operations. I strongly believe this is right what you say, and so I have seen a lot because I didn't know. So I think the younger people should come to you and learn from you and spread these techniques around the world. So this is very simple operation, transfer operation, anterior corporectomies. They are extremely big operation, and that kind of simple stabilization gives so good results. So we should learn from you and spread these simple techniques around the world. I thank you very much. This was fantastic.
Thank you.
Thank you.
I want to, Juha,
Yeah.
if somebody wants to ask me, Bin, okay, Bin, go ahead.
Yeah, Professor Atul, thank you very much. So I listened to your presentation several times, and then now although I'm not a spinal neurosurgeon, but actually, according to my understanding of your concept, I think it's a very reasonable concept because by the fixation, actually you decrease the biomechanics of the navel spinal body, and I think you change the distribution of the biomechanics of the bone and the facet. And I noticed that actually you make the spinal canal a little bit more straight, and actually you increased the space between the navel facet. So did you measure the distance of the? Maybe you can measure the body weight, body height. After the surgery, maybe the patient looks a little bit longer.
Bin, if you want to become tall, you come to me.
Yeah.
Now, Victor is here from Mexico. Victor, you want to say something?
Hello, Dr. Atul Goel and dear colleagues, Dr. Juha, Dr. Binshu, John Bennett. Thank you for giving us this opportunity to learn from a giant of neurosurgery like Dr. Atul Goel. I think that your technique is going to known around the world very fast, and I agree with Dr. Juha and Dr. Binshu. So nice lecture. I think this technique is giving us new opportunities for patients with spine disease, and also less invasive, and much easier than the invasive surgery. So I think the results is going to be very, very good.
Thank you, Victor. And I will, because this is a different concept, I will like the people in the audience to write on the chat box their comments. If they want to say, no, I don't agree, please don't agree. But if you want to write on the chat box and ask some questions, I will be happy to answer. And I see Dr. Shashwat on the screen. Shashwat, you want to say something regarding this procedure?
Yes, good evening, sir. Basically, and good evening to all. I am actually working, passed out from North, one of the college, PGI Chandigarh. Then I came to the professor 3.5 years back, actually. And the first day I saw the procedures, actually, the spines are in different angle, which I was not aware of. Then I was surprised that how the patients are acting actually post-op. Then to my surprise, when I saw the patients post-op, it was amazing, completely surprised. The patients are improved and without any decompression, addressing all the static components. So then I grew up with sir within these 3.5 years, and I completely amazing experience with all these patients from lumbar spine, Chiari, and cervical spine. It's a completely revolutionary concept, and we are blessed with sir, actually. Thank you, sir.
Okay, Shashwat, thank you. Abdul Rahim, you want to say something? Abdul is from Turkey. You see, we have over the period several people who have come. Juha, you want to ask somebody?
Hi, sir.
Yes, Abdul.
Uh,
Yes.
Well, welcome.
I am from Turkey. I have been to India twice. I saw the patient regressive disorder after C1, C2 operation, and I also think like Goel, unstable vertebra segment becomes hypertrophy, and when it stabilization after hypertrophy regression and disc regression, I think like Goel, Goel, corpectomy, laminectomy, and laminoplasty will be history like oral corpectomy, oral odontoclectomy. I like.
Thank you, Abdul. Anyone
May I-
else? Yeah, Juha.
Go ahead, Juha.
Did you have difficulties to publish your concepts?
You know,
Did your
Juha,
papers come back?
you know, Juha,
It
it
must
was not,
have been very difficult to publish in the beginning, at least.
no, not difficult, impossible. Impossible.
Oh, okay.
Impossible. How, with great difficulty, I have been able to introduce these concepts into publications. To introduce this some complete revolutionary concept is not easy. You know it, Juha. You know it. You have been in this field, and particularly from a person from India. You see, if you are in US, your concept will be easily published. Even if you say some, difficult or some unbelievable thing, your concept will be easily published if you are American. But if you are sitting in a slum, I work in a public hospital in India. To publish from India, you see, fortunately, I have been now able to publish because of my work over several years. But you know, it is impossible to publish a concept which is such dynamically different. Good that you asked me this question, Juha. I think you have experienced this with your own eyes, with your own writings, how difficult it is to get your articles with different ideas. I will suggest that ideas should not be, one small little idea is bigger than operating on 1,000 patients for 1,000 years. Ideas can change. Ideas should be encouraged. Ideas should be, published. If they are, of course, if there are some, but publication has been difficult for me. No question about it. No question.
Dr. Goel, Dr. Goel?
Yeah.
Yeah, someone is asking, do you have any publication detailing the surgical techniques?
Yes. All this, the one good thing for me is that all my sentences which I have spoken today, all the sentences are published. There is not one sentence which I have spoken on this show today is not published. And they are, you can go on Google or you can go on PubMed and you will find all my publications there. And many, I have made it a point that several of my publications I have given on this presentation, which will be now recorded by Neurosurgical TV and which will be available on Neurosurgical TV. So you can get those publications. And if you are having difficulty in getting those publications, I will be very happy to send those publications to you.
Yes, and you also have a sizable archive of videos that you've done with us over the years, Dr.
Yes.
Goel. Now, Mahesh Krishna asks, do you use allografts as distractors to achieve long-term stability?
That's right. That is a very fantastic question. You see, basically my surgical technique depends on arthrodesis or bone fusion. For bone fusion, you need to do 3 steps. One is open the joint. Second is remove the articular cartilage. I introduced this slide as a very first, one of the very first few slides I introduced this. Open the joint, remove the articular cartilage, and introduce bone graft in the joint. That is the bottom line of my concept. So when I do multi-level fixation or do C1, C2, I always use patient's own bone from the iliac crest. Iliac crest is a beautiful bone graft, and I always use iliac crest. I don't use artificial bone. I don't use expensive bone material or glue or all those kinds of expensive material, because I do not believe in those, and also my patients will not be able to afford those kind of expensive material. I work in a public hospital essentially, and essentially I use whatever is I feel is the best for the patients.
Okay, very good.
Sure.
More comments? Go ahead. Go ahead. You have a comment?
Dr. Khan wants to ask.
Professor Atul Goel, thank you very much. That was a beautiful lecture. Dr. Muhammad Fareed Khan, right from here, Lahore, Pakistan. Always remember your visits to Lahore General Hospital. It's a pleasure seeing you. And excellent presentation as always. Always admire your contribution to the field of neurosurgery, and hope to listen to you again and again. And bless you. Lots of prayer from Lahore.
Thank you, Dr. Khan. And you must know, Dr. Khan, that I was very, very famous in Pakistan.
True.
Unfortunately, nowadays, you know, the problem between India and Pakistan, the travel has become so difficult, but we are now communicating. I am giving several webinars to Pakistan Neurosurgical Society, several recently on Neurosurgical TV, and in with Salman Sharif, and with various other Dr. Raja from Hyderabad, and with several, you know, I'm coming on webinars and addressing Pakistan society. So thank you, Dr. Khan, for giving me those wonderful comments. Thank you.
Bless you.
Okay, more comments or questions from the panelists? Now's your chance. Dr. Harshad, how are you doing? You arrived a little late.
Dr. Harshad is also one of my very favorite, John. Dr. Harshad has heard at least 100 of my lectures on neurosurgical TV. I will be happy to hear Dr. Harshad's comments. Harshad.
Okay. Good. Unmute, Harshad. Unmute.
Hi, Atul.
Thank you, Harshad. Thank you.
We are there since many, many years together, and I've seen you growing in stature. And I agree with you in every aspect. You have revolutionized the treatment of C1, C2, and now you're coming back to the complete change in the spinal surgery, degenerative. And I'm happy that you are removing the word decompression. Excellent. We believe you.
Thank you.
I've seen you doing it, and there is no doubt about it. Your capability and your stature, which you are showing. And there's nothing to doubt about it. And you are bringing every time something new. I must have listened to this lecture n number of times, and every time I feel I'm learning again. Something new is learning.
That's great. Always great to hear. Now, Dr. Mohammed Helmi has a question. Do you want to ask the question, Mohammed, directly to Dr. Goel? Are you there, Mohammed, from Egypt? Well, perhaps he isn't, but let me read you the question. Have you figured out the correlation between the spinal problems and patients' professions? In other words, people with sedentary work or those who are physically inactive, which may worsen their spinal muscles.
Absolutely, absolutely. And this gives credence to my hypothesis. You see, the people who are heavy workers, laborers, and do heavy work will never get spinal degeneration. People who are sitting on the computer, people sitting in the classes, people working desk, people who are sedentary jobs, those who consider themselves retired. You see, those who consider themselves retired will, and those who walk slowly, because I am retired, I cannot walk fast. You see, those who retire will certainly retire. It is in your mind. If you think you are retired, you will be retired. If you think you are strong, you are able to work, you will never retire. If you think you can run at the age of 70, at the age of 80, you will not retire. Your spine will not retire. Because you think that you are weak, you will get spinal degeneration. Because you are not exercising your body enough, you will get spinal degeneration. Your job will determine your spinal degeneration. If you are working on the computer all your life and you are not exercising, you are not running on the beach like John does. You see how smart John looks. You see John will never get spinal degeneration. You see the Miami Beach behind his back. He's running on the beach. I don't know what he does when he runs and what he sees when he runs. I don't know. But he's seeing some, and his brain also works. You see, what you see and what you do will determine what you will be. And that is my concept, John.
Very good.
This concept, John, is not in the literature. Nobody has related your profession to spinal degeneration. I am saying because you are not working enough, you are not exercising enough, you will get spinal degeneration.
Very good. More comments or questions from the audience? Okay, let's see here. Let me just go through the panel, Dr. Goel, to see if I missed the question. Okay, I think I got most of the questions. Do you see any questions there at all that you maybe, can you see the panel from there?
You can ask people, you know, Juha, you want to ask more questions to me, Juha?
Well, we may be ready to wrap up then. Okay. And like I mentioned, our Dr. Goel has an extensive archive of videos on neurosurgical TV over the years, if you want to see a lot of videos. And do you have a website, or you have a place where you keep all your videos, Dr. Goel?
Yes, you have made a channel for me. You can announce that channel, that Atul Goel channel.
Okay, I'll do that. I'll do that. Very good. Okay, any closing comments, Juha?
Okay, today is a Chinese Lantern Festival. Actually, in this festival, Professor Atul Goel attracted more than 2,300 audience.
Oh, excellent.
To attend this webinar. Yeah,
Excellent.
Congratulations. Yeah.
Excellent. Okay, I don't know if we got the Japanese translation today. I'm not sure, but we always get a lot of people when Dr. Goel speaks. Okay, I guess we'll end this broadcast.
Juha, because before we end, John.
Yeah, I'm waiting. Is Juha, you still here? He may have stepped away.
Juha, can you unmute? Unmute. You unmute, please, Juha.
Okay, sorry. Yeah. Sorry. So it was a great lecture. Thank you very much, Atul. We are very happy. You are coming also next Friday. What are you speaking next Friday?
Next Friday, I will talk on arteriovenous malformation surgery.
Oh, that's wonderful. That's wonderful. Okay. This will be again a passionate lecture. So we are waiting for that, and we wish you all happy weekend, and in China, good night. The others have the day in front of you.
Okay, very good, Juha. Okay. Thank you very much.
Bye. Thank you very much, Atul.
Bye-bye. Thank you. Bye-bye.
Bye-bye.
Okay, we'll end this book. Thank you, everybody.
Bye-bye.
Thank you. Thank you.
Okay, we're off the air, but I want to show you guys, we have a webcast tomorrow with the French Grand Rounds, and Dr. Cabulo, who's going to give the lectures here. Are you here, Dr. Cabulo? Or did he step away? He may have stepped away. Anyways, this channel is going to be in French, and the French language, I was surprised, covers a lot of Africa. And it's actually, this series will be put together by Saeed Taha. He's a neurosurgeon from Reunion, off the coast of Africa. That's French speaking. Did you realize that you have a lot of French speaking in Africa? A lot of those countries are French speaking.
Coming from the colonial times.
Yeah, we had a webcast with one group from the Congo, and it was very well attended in French. We had a lot of African panelists there. But so we have that activity. And does anybody want to say hi to Juha? Juha's here. This is your chance. And Dr. Goel, okay. I mean, come on, you guys. Friday. Well, I know if I was a student or a resident, I'd say, hey, Juha. But hey, Dr. Goel. And Ben's here too.
Yeah. Okay, in any case, what I do is I wish you happy Chinese New Year and enjoy yourself and enjoy the weekend. Bye-bye.
Oh, thank you, Dr. Goel. Thank you very much.
Thank you. Thank you.
Bye-bye. Enjoy.
Bye-bye.
Bye-bye.
Thank you. Thank you.
Bye-bye. Happy Chinese holiday, dear colleagues.
Chinese New Year.
Hola, Bennett.
Hey, who's that?
Amigo Bennett.
Oh, Victor, ¿cómo está? Tú promotion bien. Do promote good.
Yeah. We'll be there tomorrow for the lecture of in French.
Oh, tú hablas francés?
A little bit, just a little bit.
Oh, okay. Déjame ver, déjame mostrar la banner. Déjame ver. Oh, aquí está. A los panelistas también, o las personas están mirando. Ok, ahora, Victor, ahora es un tiempo para network. Después de la charla. Okay, here it is, Victor. Here and everybody else. This is
Yeah. I see it.
Yeah, Warlick did the banner.
Okay.
French neurosurgery grand rounds in French.
Yeah.
La abscess cerebral.
I'm going to put it in several chats.
I'm sorry, you want me to what?
I'm going to show it, the cartel, in several chats.
Oh, good. Yeah, necesita promoter. Necesita promoter esto. Y también hay un Rusia aquí. Un español que está en Rusia. ¿Está allá, José? ¿O se fue? Déjame ver. Hay un neurocirujano de Belgorod, Rusia, Victor.
Yeah.
Y él quiere dar lectura de Belgorod. ¿Está allá?
Hola, ¿cómo estás, John?
Está, ok. Luis, ¿cómo estás?
Yo muy bien, acá con frío, temperatura ahorita 5 grados, pero estable, todo tranquilo. Me habías comunicado que el sábado habrá la ronda de neurocirugía Rusia, entonces gracias por incluirme y por tu consideración. Vamos a presentar ahí algunos temas. Gracias.
Oh, ok. ¿Y cuántos años en Rusia?
No, yo estoy haciendo mi programa de residencia. Tengo 3 años acá viviendo. Me tocó aprender.
¿Habla Rusia bien?
70%, 80%. No puedes aprenderlo. No puedes aprenderlo 100% en un año. Requiere mucho tiempo aprenderlo.
Oh, ok.
Pero es un idioma muy bonito.
Tenemos charlas en español también. Y sábado tenemos un charla. Victor, déjame mostrar, ¿ok?
Okay.
No sábado. ¿Cuándo está su lectura, Victor? Martes, ¿verdad?
El martes tenemos un caso de cirugía, dos casos de cirugía de columna vertebral.
Ok, déjame mostrar esto.
Va a estar el doctor Paulo Pereira, que es el presidente del Comité de Premiaciones a Neurocirujanos Jóvenes de la WPNS.
Paulo Pereira de España,
de
¿no?
Portugal.
Portugal, perdón.
Si yo tengo la bandera, yo voy a mostrar. Un segundo, no puedo encontrarlo.
Luis, ¿de dónde eres? ¿De dónde eres?
Yo soy de Ecuador.
Excelente.
Soy de Ecuador.
Guayaquil.
Guayaquil, sí, hay una colonia muy grande de latinoamericanos en Europa haciendo neurocirugía y lo seguimos siempre a los latinoamericanos, a los mexicanos, a los webinars mexicanos, brasileños. Estamos siempre pendientes acá, aunque el cambio de horario, a veces me toca ver webinars en la madrugada, porque empiezan webinars a las 8 de la noche de Latinoamérica, y acá sería en la madrugada. Pero vale la pena Y John, te felicito porque me acuerdo en el 2016 nos íbamos a encontrar con John en Miami, ¿te acuerdas? No sé si te acuerdas. Y hablábamos y te comentaba, oye, de tu página y si le das volumen y si sigues vas a ver que vas a dar un aporte grande a la neurocirugía. Y mira, ya han pasado bastantes años.
¿Tú has visto la bandera? Víctor, explica este congreso.
Sí, este curso va a ser organizado por 4 hospitales muy grandes, muy representativos de la neurocirugía en México. Y ahí van a presentar 2 casos para discusión, son casos clínicos de discusión. Uno va a ser presentado por el doctor Paulo Pereira, nos sentimos honrados de que esté este prestigiado neurocirujano portugués con nosotros. Y los otros casos van a ser presentados por el Hospital 20 de Noviembre, Hospital 1 de Octubre, Hospital ABC y el Hospital Germán Díaz Lombardo. Entonces, creo que van a ser muy buenos casos. Ojalá y nos pueda seguir, Luis.
Por supuesto que sí, estoy conectado a todos los webinars que hay en el mundo, así que...
Sí, tú estás en la lista de mailing list, ¿verdad, José? Tú estás en mailing list porque tú vas a recibir noticias de todos los congresos. Tenemos varios en español. Cada 2 semanas tenemos uno en español. Pero mira, ¿tú conoces Manuel en Canción de Moscú?
Claro.
Oh, ok. Él está de República Dominicana.
Sí he escuchado de él, pero no soy amigo de él. Yo estoy en otra ciudad, él creo que está en otra ciudad, pero no lo ubico. O sea,
Sí,
lo conozco.
sí, Belgorod es lejos de Moscú, ¿verdad?
Belgorod es frontera con Ucrania, estoy al sur de Rusia. No estoy tan frío como al norte. Pero ahí estoy a 120 kilómetros de Kharkov y 200 kilómetros de Kiev, la capital de Ucrania.
Sí, el invierno es diferente que Ecuador, ¿huh?
No, mi ciudad Guayaquil es 32 grados, o sea, me estoy quemando ya. Yo acá he venido a experimentar
Frío.
Menos 20 grados, es increíble.
Víctor, ¿tú puedes vivir en un clima como esto?
No, yo estuve un año en Detroit, estuve un año hace como 25 años, y en Detroit, en el norte de Estados Unidos, sí hace mucho frío, pero pues te adaptas, ¿no? Pero fríos como los de Rusia no los he experimentado. Lo más que llegué a experimentar fueron 15 grados bajo cero, pero más ya no, y es un frío terrible. Entonces, comprendo y sé lo que estaba hablando José.
Luis.
Perdón, Luis.
Bueno, pues mi estimado Víctor, un gusto poderlo conocer también. Yo lo sigo mucho porque usted le da un aporte a la neurocirugía también. Lo he visto en ciertos webinars de la World Federation y lo felicito también porque los mexicanos están dándole duro a la neurocirugía. Eso es muy bueno, ¿no? Extremadamente bueno. Lo felicito.
Ok, Luis, ¿tú quieres dar su charla en Rusia, en Russian?
Oh, en ruso.
Sí, yo quiero que tú das la presentación en la lengua de Rusia. Para los otros neurocirujanos de Rusia.
Sí, lo que pasa es que los neurocirujanos rusos, ellos no escuchan muchos webinars latinoamericanos. Y tu página acá no es muy conocida, aquí en Rusia, usualmente tu página la conocemos todos los latinoamericanos. Pero bueno, no tengo ningún problema, tendré que prepararla en ruso, así que pues...
Sí, puede hacer en Rusia, por favor. He hecho antes. Yo voy a mandar varios charlas de neurocirujanos de Rusia. Uno de, ¿cómo se dice? De varios temas. En Rusia, en Russian.
Dime una cosa, John. ¿Quiénes son los otros participantes que van a hablar en ruso? ¿También van a haber otros o solamente yo?
Sí. No, yo voy a publicar en Neurosurgical TV y para Rusia, otra Rusia del mundo, para venir, para participar.
yo tengo unos amigos de Moscú, de Burdenko, que pueden participar
Sí,
también.
oh, excelente.
Que preparen un tema y pues hablen ellos en ruso, ¿no?
Sí,
También.
Rusia es un país perfecto para Zoom, perfecto. Tú puedes conectar a todas partes de Rusia. Yo puedo, si da la oportunidad. Rusia es perfecto para Zoom, perfecto.
Sí, sí, voy a hablar con unos colegas de rusos para que se comuniquen contigo para que pues ahí coordinen la charla.
Ok, vamos a empezar con su show. Tu programa es la primera. Y voy a decir, vamos a empezar un canal nuevo de Rusia, una charla de Luis sobre cualquier tema que quiera hablar.
Tengo
Y
algunos
vamos
temas
a ver cómo va.
Tengo algunos temas ahí, claro, ahí vamos a hacer la participación de ahora la jornada de neurocirugía de Rusia. Está bien, me parece bien, interesante.
Okay.
¿No?
Cualquier tema, vamos a empezar pequeño. Va a estar lento en principio para construir en comunidad, pero es un futuro, es un futuro.
Sí, el futuro. Te digo que acá en Rusia hay muchos latinoamericanos, o sea, brasileños, mexicanos, de Centroamérica, haciendo cirugía acá y hospitales importantes. Bueno, pues la verdad voy a tener que
comprar tacos en Belgorod. Si tú vas a la tienda y preguntas para un taco, ¿qué va a decirte?
Bueno, pues estamos conversando, John, y pues ahí te avisaré el tema que voy a mencionar y pues estaremos hablando, ¿ya? Hoy día te aviso quiénes son los participantes que pueden ayudarnos.
Ok, perfecto. Vamos a empezar con la primera charla. Déjame determinar qué parte del día está bien. Es mejor, yo creo, a las 4 o 5 más o menos de la tarde en Rusia, en Belgorod.
Ahorita son 5:15 de la tarde. Yo creo que esta hora está perfecto. 5 de la tarde. Es una hora tranquila.
Ok, tú estás mi amigo en Facebook. Podemos comunicar sobre esto, ¿ok? Y ok, muy bueno, muy bueno.
Invítalo al el colega que me mencionaste de Moscú. ¿Cómo que se llama?
Invita a todo. Invita todo. Bienvenidos. Yo voy a hacer una página para mandar a ellos para la información, para el link y para el subjecto de la charla. Y mi plan es para poner un canal. Tú has visto los banderas, ¿verdad?
Sí.
Sí, un neurocirujano de Thailand hace estas banderas. Muy bueno, muy bueno. Y vamos a hacer una bandera para Rusia, Grand Rounds.
Tengo amigos también, colegas latinoamericanos que están también en Alemania, ¿no? Podríamos también hacer un canal de Alemania también.
Ok, vamos a el mundo, el internet va a todo el mundo. Y es gratis. ¿Qué arma? ¿Qué arma para tener una máquina que va a todas partes del mundo gratis? Casi gratis.
Sí, tienes razón.
Es un, wow, durante mi vida, wow, esta parte es lo mejor de computadores. La vida, cuando computadores empieza, yo empiezo a vivir.
Ya. ¿Qué te iba a decir? Bueno, pues hay que hacer algunos webinars de Europa también, ¿no? Hay muchos, como te decía, hay mucha gente por acá también haciendo neurocirugía en hospitales importantes.
¿Sabes qué, Luis? No ha tenido mucho éxito atrayendo a Europa de Alemania, de Francia, hasta ahora, pero con tiempo va a adaptar,
Te comento
yo creo.
no, lo que pasa es que, a ver, lo que pasa es que los europeos están muy avanzados en neurocirugía. Ellos tienen ustedes se han podido dar cuenta, los webinars que proyectan los europeos es extremadamente muy complejo. Lo académico, el material que ponen en sus webinars es extremadamente buenísimo, alta calidad. Lo que pasa es que ellos no se promocionan tanto, ellos no son tan propagandistas. Ellos, por ejemplo, organizan un webinar y no es que sale a la luz por todos lados. Los neurosurgeons europeos son así, los rusos también son así. Son más como que cerrados su país. Por eso
Sí.
que las asociaciones de Europa a veces lanzan un webinar y lo hacen una vez al año o 2 veces al año. Pero como lo hace Latinoamérica, México, Brasil, que lo hace cada semana y se propagandiza por todos lados, pues, se hace muy reiterativo, ¿no? Mira que los cirujanos de la India, pues qué extraordinario nivel, el profesor Atul Goel, extraordinario, ¿no? Pues sí, también se proyectan y están cada vez haciendo webinar de un nivel impresionante. Me impresiona también. Y los chinos también. Yo sé que es el problema, no son tan propagandistas, John. Entonces los europeos se reservan más a ellos, son webinars que organizan solo para ellos, a veces de su hospital, entonces por eso que no se escucha mucho en Latinoamérica, pero Europa tiene mucha cosa, mucha tecnología,
Pero
mucha para
sí,
neurocirugía.
sí, Luis, sí estoy de acuerdo contigo. Nada más que, por ejemplo, la neurocirugía en la India, igual tienen una experiencia muy vasta. Es increíble lo que hacen
Sí,
los
mucha
amigos,
experiencia,
mucha experiencia los colegas de la India.
sí.
Ahí está el doctor Tamina Aib Sherian, el doctor Keki Turel, el doctor Atul Gol, el doctor Harshad, muchos más. Pero yo, por ejemplo, he quedado impresionado porque he tenido la oportunidad de ir en 3 ocasiones a China